رح نسوي quick review about pediatric neuroradiology cases. Let me go over. Okay, so هذه الويب سايت اللي مطلوب انه تروحون عليها، تدوسون على هذا اللينك. I think دكتور رعد دز لكم اياه، فحتى انه هي الطريقه اللي تجاوبون بيها الاسئله، ويعني انطوني بالاخير الفيدباك مالتكم اذا عجبتكم ولا لا. صراحه احنا هنا الريزدنت تعجبهم انه هي تسوي حتى ما يكونون هم under focus ولا انه هم اللي يحجون. So it's away from what they call it hot seat. وبعدين هي جزء من عندها انه هو البورد اكزام هنا بطلوا يسوون الاورال اكزام، فهو كله كمبيوتر بيزد ناو. فصارت انه ايزير انه خلص كل واحد بمكانه ويجاوب. الاذر بنفيت انه انت يعني we can go over more cases لما يعني you just click on the answers rather than انه we wait for everyone to talk and then discuss. so تقدرون تشوفون اكثر كيسات خلال الوقت مع الساعه مثلا. فاذا كلكم جاهزين، طبعا هو اكو ليميت، احب اقول انه هو اكو ليميت لانه همتين فري هذا الاكونت، فاكو ليميت بيه كانه 40-50 واحد اللي يقدرون يدخلون. فللبقيه انا افضل انه هم السنوات الاخيره هم اللي يدخلون بيه، والبقيه يسمعون طبعا، يشوفون الكيسات ويسمعون الاجوبه. فاذا جاهزين نبلش. اول كيس فاني اقدر اشوف من هنا اللي يجاوبون. رح ننتظر فد 20-25 واحد حتى ما ناخذ هوايه وقت، وبعدين ابلش اشوف الجواب. Okay, so ممتاز. 100% corpus callosum. Okay, so corpus callosum genesis, there are certain findings on axial plane. So part of it's absent cavum septum pellucidum, colpocephaly, which is the enlargement of the posterior occipital horns of the lateral ventricles, and then the parallel configuration of the lateral ventricles secondary to absence of the propost fiber, the connecting fiber in between that crosses through the corpus callosum. That's what results when it's absent, result in parallel configuration of the lateral ventricle. On the coronal, still absent cavum septum pellucidum, but then you also have the certain appearance, they call it either Texas horn or moose head appearance for the frontal horns of the lateral ventricles, elevation or high riding of the third ventricle, and then on the sagittal, which is the easiest one, where you see absence of the corpus callosum, but you also see the approximation of all the gyri towards the midline. Once you see absent corpus callosum, then you would think of any associated abnormalities, whether within the brain or within the body. Okay, next case. I think most of you saw this case, and you did the answer for this case, just trying the website. Okay, so it's medulloblastoma. We get another question.
Both.
Okay, good job. So it's a case of medulloblastoma. Part of the main things that you see, so that's T1, T2. In medulloblastoma, most of the time there will be it's a more packed, highly packed cells. So then you will get high density on low density on the CT. It will be high density on the CT, but low intensity on T2, and then you will get mostly homogeneous enhancement. However, there are certain variants that can be different. And then then the main thing, they will have the restricted diffusion on diffusion-weighted images. You would say that there is restricted diffusion once you see on the ADC that it looks at least similar or slightly higher than the adjacent brain parenchyma. So look carefully for ADC signal. That sometimes it can be tough on just saying by the diffusion-weighted images. And once you have fourth ventricle mass lesion, then you will get supratentorial ventriculomegaly with transependymal CSF flow. That's the new terminology rather than the transependymal CSF flow or periventricular interstitial edema. And also you will see prominence of the optic nerve sheaths with flattening of the posterior sclera, which tells you that there is papilledema. That's how we can radiologically say that there is papilledema, which is also related to elevated intracranial pressure. So it's differential diagnosis for pediatric posterior fossa tumor. It's the pilocytic astrocytoma, usually solid and cystic, but there is no restricted diffusion. You will have medulloblastoma or ATRT. Both ATRT is the atypical teratoid rhabdoid tumor. Both are high-grade malignant tumors, and both can happen within the posterior fossa. But the ATRT is usually happening in a younger age group. And again, because it's packed cells, so it's hypo on T2, hyper on CT, hyperdense on the CT, restricted diffusion. And if you have any sort of perfusion images, then it can look as increased perfusion. On the other hand, you have ependymoma, which is more as like plastic tumor or insinuating tumors that goes through the foramen, Magendie or Luschka, and it's more as like more heterogeneous blood product calcifications. Hemangioblastoma, it's still cyst and nodule, but it's usually not really a pediatric lesion. It's more in young adults, like more around 30 in age. You have choroid plexus papilloma. It can happen within the fourth ventricle. However, most common location in pediatric is within the atrium of the lateral ventricles. If it happens in adult, then the fourth ventricle is the most common location. Okay, next case. Take a look before we get to the question. So I'm not sure if there's something within the chat. I'm not checking the chat. If you have any question or you want to ask anything, you can stop me anytime. Okay, so most of you get it correctly. It's great. Okay, next question. Okay, that's good too. So it's a case of an F1 with hypothalamic right optic nerve glioma. So part of the findings of an F1, you get all these foci. It has specific distribution. So it's more within the globus pallidi, putamen of the basal ganglia, but also within the thalami. And then you get some of these lesions within the brainstem. So you have within the middle cerebral peduncle, and then within the dentate nuclei of the cerebellar hemispheres, here within the medulla. and you get the astrocytoma, which is the most common pilocytic astrocytoma. So it can happen anywhere along the optic pathway. So you have here the hypothalamic region, but then you get some within, it gets starting from the optic nerve in this patient, and it gets some heterogeneous enhancement. So NF1 is autosomal dominant disease, part of neurocutaneous disorder, or what they call it phacomatosis. Part of the manifestation, we talked about the brain and all these white matter bright spots related to myelin vacuolization, optic pathway glioma, but then there is other manifestation which is vascular, such as moyamoya or aneurysm. There is some skeletal changes. You have sphenoid wing dysplasia, posterior scalloping of the vertebra, and tibiofibular pseudoarthrosis, which is an anterior pseudoarthrosis that's different from when it's related to foot abnormality, usually posterior pseudoarthrosis. And they can get plexiform neurofibroma anywhere within the body, and glaucoma with macrophthalmos. So in this case, you just click where is the abnormality. Right here. Okay. So I see we're all over the places, but there is more focus within the posterior fossa. Oh, interesting. I know why is this stayed here. Okay. So the next question. Okay, good job. Okay, so this is a fetal MRI, and then by the end of the lecture, you can guys tell me if you are you doing fetal MRI in Iraq. I don't know, like I'm not there. So and it's a case of Dandy Walker malformation. You see a large posterior fossa and hypoplasia or almost absence of the vermis, keyhole appearance, and then hydrocephalus. So posterior fossa cyst, or enlargement of the posterior fossa, or what they call it Dandy Walker continuum. It's more starting from being more severe to mildest form. So the most severe is the classic Dandy Walker malformation, moving to Vermian hypoplasia, Blake pouch cyst, and then megacisterna magnum. We'll talk briefly about each of these. So the classic Dandy Walker malformation is the case that we saw, and that has specific three triad of Vermian agenesis or hypoplasia, large posterior fossa with the cystic dilatation of the fourth ventricle, and the elevation of the torculum, and which is this is the region where the superior sagittal sinus meets with the transverse sinuses. So elevation, and not just elevation, however, there will be inversion, what they call a torcular lambdoid inversion, where the torcula become even higher than the location for the lambdoid, where the two lambdoid sutures meet. Vermian hypoplasia, so there's variable degree of Vermian hypoplasia, but can be associated with some rotation, but there is no enlargement of the posterior fossa, and then the torcular lambdoid relationship is within normal. Blake pouch cyst is elevation or increase in tegmentovermian angle. I will show you how we really measure the angle. Usually this angle is around 0 in normal patient, but then it will become more than 30 with a Blake pouch cyst. And it's mostly there is opening of the fourth ventricle with what looks like cystic dilatation. However, you don't see clearly the line of the cyst unless you do some of these high heavily weighted T2 sequences, such as the CIS on semen, or the space, or when you give contrast, you can see the choroid plexus along the surface of the fourth ventricle, but there is no posterior fossa enlargement or torcular lambdoid inversion. And then megacisterna magna can result in large posterior fossa, but there is normal vermis and cerebellum size, and so only the retrocerebellar CSF spaces are increased, becoming more than 10 millimeter. The way that you can tell this versus arachnoid cyst, which is basically the same, large posterior fossa and then prominent CSF spaces, is if you see pressure effect on the cerebellum or the vermis or the calvarium, then you would call it arachnoid cyst rather than being just a megacisterna magna. So these are just another examples. So classic Dundee Walker malformation, again with very large posterior fossa and torcular lambdoid elevation. Normally the torcular lambdoid, if you draw a line, it should come through the mid of the midbrain. But in this case, it's going way high up where the torcular location. And then this is the vermian hypoplasia. So small vermis, posterior fossa is not enlarged. And then still this is the lambdoid where the two lambdoid suture meet. And then that's where the torculum, there's no inversion. And then this is Blake pouch cyst. So the tegmentovermian angle is that the angle between these two areas. So we're between the vermian surface of the vermis and then the tegmental surface. And this angle here becomes increased that's the cyst here. So this is on heavily weighted T2 sequence. You see the wall of the cyst, or sometimes you can see the choroid plexus on post contrast wrapping around the inferior surface of the fourth ventricle. And this is just a megacisterna magna with a prominent, again, this is another fetal MRI with just a prominent posterior fossa, but we see that the the vermis looks fine. There is no hypoplasia of the vermis. Okay, another case. Okay, variable responses. Well, so it's just so we go back, it's the first bronchial cleft cyst, and that's what we're going to talk about. So bronchial cleft cyst, it's a cystic structure. So then an ultrasound, most likely it's anechoic, or there is fine to coarse internal echoes. There will be some thickening of the wall and some inflammatory changes if it is infected. The same for CT, well-defined, low density. It can have a little bit of just like enhancement of the wall, just a thin enhancement, but if there is more thickened enhancement or there is any inflammatory changes, that's in case of infection. And the same for MRI. For the first bronchial cleft cyst, this one, think about it always as being periauricular, and it has a relation to the external auditory canal. So there are different types, and either one, it's based on the embryology of these things. So it can result in otitis externa, or can result in recurrent parotid abscesses. Okay, Joe? Okay, great. So yes, it's a case of DNET. and I'm glad that you guys get it correct. So it's a cortical-based tumor. There is not much of edema around it. Maybe I can convince you that there is some bubbly appearance here or there, and no restricted diffusion because it's WHO1. So what are the cortical mass lesion? Or cortical-based mass lesion. So ganglioglioma is the most common, usually non-cystic. It has calcification and enhancement. DNET is more as a benign one, WHO1, and most commonly within the medial temporal lobe, but can happen anywhere else. And yes, it's the bubbly or sub-bubble appearance, minimal or no mass effect, and not much of edema or enhancement. Oligodendroglioma, most commonly within the frontal lobe, it has calcification around 90%, more cystic component, and it's more within the middle-aged adult. So it's not really a pediatric differential. And then PXA, pleomorphic xanthoastrocytoma, it can also be as a cyst and enhancing nodule. However, there will be enhancement of the adjacent pia, so it can give a dural tail and PL enhancement. That's why we say for the dural tail, it's not specific for meningioma or not pathognomonic for meningioma because it can happen in other tumors. Okay. Okay. So it's an astrocytoma. And I agree with the confusion for this one. It's just I put it here for review. Sometimes it's so hard to really tell these things apart, and that's why as part of review I have this table. So astrocytoma is more common in pediatric compared to ependymoma. They say it's more common in adult. Astrocytoma usually will have longer cord segment of involvement, and by that they consider 4 vertebral body levels. So if it's more than 4, that's what they consider it as longer segment. And then usually the margin is indistinct and it's more infiltrative and eccentric in location. Compared to ependymoma, again, it's shorter segment, central in location, more well-defined, and then it has the cap sign, which is on T2 or if susceptibility signal. So then you will see an area related to hemosiderin deposition around the poles of the tumor. And that's an example of ependymoma in 35-year-old. So it's more well-defined and then more central in location in an adult patient. Okay, next case. Oh my goodness, trying to use my answers. Okay, there we go. Okay, we'll see. So yes, it's spine MRI, and for the reason that this case is Chiari-2 malformation, there is certain findings that would tell you from the brain MRI that this is Chiari-2 malformation. If that baby is just born, then you will definitely need the MRI. I'm assuming later on they should know that the baby has Chiari, and then so in this case, This is post-surgery. They repaired the myelomeningocele, but you still see the tethering of the cord with what they call it the posterior neural placode is all posteriorly pushed and tethered to where the sacral dystrophism. So Chiari-2 malformation, it's from the entity of small posterior fossa. You have cerebellar tonsillar ectopia. You have dysgenesis of the corpus callosum. Usually for the corpus callosum to say that there is posterior dysgenesis, you should have the splenium. So for the corpus callosum, there is genu, body, isthmus, and then splenium. So you should have the splenium, the AP diameter for the splenium as big or bigger than the genu. If that's smaller, then you would call it some sort of dysplasia, like it's formed, but it's not fully normal, or hypoplasia where it's smaller than normal. And then, for example, in this case, we also lose the isthmus. So the isthmus is the narrowest portion. It's similar to the isthmus of the fallopian tube. It's just a very narrow segment. But in this patient, it's almost like similar thickness between the body to the isthmus. So that's sort of corpus callosum dysplasia. Beaking of the midbrain, so the tectum of the midbrain is beaked, as you can see here, and then Fox insufficiency. So there is deficiency within the Fox, some areas of deficiency. That's what results in interdigitation of gyri. You see that this gyri is crossing to the other side. Thickening of massa intermedia, which is the structure between the two thalami of non like exact significance, but it can get big in certain entities, congenital entities. One of it is Chiari-2, and then subependymal heterotopia and polymicrogyria. So these are the heterotopia. Sometimes these heterotopia can be easier to see on diffusion weighted images just because it can look bright, similar to the cortex. Ventriculomegaly, and then the myelomeningocele with the open skin defect. Okay, another case. Let's see. Oh, wow, good job. Okay, so yes, it's a case of von Hippel-Lindau syndrome. That's the CT appearance for the patient. So just a cystic lesions, but also there is supratentorial ventriculomegaly. And usually the patient will present with the CT. And then for the MRI, so you see the cyst and nodule with the surrounding edema. And because of all these changes within the posterior fossa, it narrowed the fourth ventricle, resulting in supratentorial ventriculomegaly, and then the transependymal or periventricular interstitial edema. And you see the enhancing nodule. On spine MR, there is some of these nodule that's enhancing. I mean, it's still part of hemangioblastoma, but there is no cystic component. And then you see all these cystic changes within the pancreas. So von Hippel-Lindau's autosomal dominant can affect 6 organs, young adult patient, as we said, and then you have within the brain and spine hemangioblastomas. Eye, you can have angiomas, ear endolymphatic sac tumor. I will show you a case, and then clear cell renal carcinoma, pancreas and liver, cyst and islet cell tumor, pheochromocytoma within the adrenal gland, and then cyst within the epididymis. And this is a case of endolymphatic sac tumor. So where the endolymphatic sac is located where you can see the vestibular aqueduct. So this is the cochlea, and then this is the vestibule, and then here it should be the posterior semicircular canal. Next to it, we should look for vestibular aqueduct. So in this location, that's where the endolymphatic sac can sit. And then if you see any what looks like erosive changes within the bone with some enhancing component on post contrast, then this is part of endolymphatic sac tumor, which most likely seen in von Hippel-Lindau syndrome. Okay, another case. Let's get that answer. Oh my goodness, sometimes I lose my arrow, sorry. Yes, Potts-Puffy tumor. So Potts-Puffy tumor is part of acute sinusitis complication, which is related to the frontal sinus. It's misnomer for sure. And you know that there is acute sinusitis because you can see fluid level. So that's the only way in radiology that we can tell it's acute infection. And then you see what looks like an osteomyelitis with a subperiosteal abscess along the frontal sinus. Part of the other differential that I put is the Bizold abscess, which is related to acute automastoiditis. So we know when there is automastoiditis, there is always the risk of eroding the adjacent bone, and then can result in intracranial, either just effusion, empyema, or even venous thrombosis. But in this case, with what they call the Bizold abscess, it's related to an external erosion, and then the abscess material or the pus material will be along the sternocleidomastoid muscle and can extend to infratemporal fossa. Lemierre disease, that's an important one. It's related to oropharyngeal infection, pharyngitis, tonsillitis, and then the association of internal jugular vein thrombosis. And then the other checkpoint that you should check anytime that you read neck CT for a child is for the epices of the lung for any septic emboli that you can see. So the venous structures, and then for any septic emboli related to Lemierre disease. Okay, another case. Another fetal MRI. Okay. So it's Chiari 3, not Chiari 2, and it's related to occipital, what they call it occipital encephalocele, or Chiari 3, related to low occipital or high cervical meningoencephalocele that can contain the cerebellum, the brainstem, meninges, CSF, and vessels. There's a midline defect within the occipital bone, can be associated with other syndromes. Part of this is Michael-Groger, Goldenhar syndrome, Warburg, or amniotic band. So it can be associated with some other syndromes. And that's the postnatal picture for the patients. Basically the same finding with the encephalocele, and then atrophic or very hypoplastic cerebellar hemisphere and vermis, and even the brainstem, and it's all attracted to the encephalocele. Okay. So Sturge-Weber syndrome, so with the Sturge-Weber syndrome, part of what you see, for example, in this patient, there is an asymmetry between the two hemispheres. This hemisphere is smaller, but also there is some abnormality within the white matter signal, and there is some of this leptomeningeal enhancement, which you can see even early on the disease process. So what's Sturge-Weber syndrome, or encephalotrigeminal angiomatosis? There is port Weinstein, seizure, hemiparesis, and it's all related to some abnormal cortical venous development. With that, then we would get the imaging findings related to venous occlusion, recruitment of an alternate drainage pathway, and resultant chronic venous ischemia. And this one is still part of the phacomatoses, but it's a non-hereditary disease. For the CT, we can see the gyral or subcortical calcification, giving us the trauma tract appearance, and then the volume loss. Secondary to that, we can have the calvarial thickening and hypernematization for the sinuses. On MR, we can see the atrophy. We see an abnormal myelination and an abnormal signal within the cell site related to leptomeningeal enhancement. Also on susceptibility signal or any GRE sequence, we'll see the calcifications. It gives the signal of susceptibility. And in addition to enhancement of the leptomeninges, you can see enhancement of within the choroid of the orbital choroid. There will be enhancement of angiomas and enlargement or enhancement of ipsilateral choroid plexus. So the same side where there is the atrophy and the leptomeningeal enhancement, it can have associated enlarged choroid plexus, again, because of all the change in venous system. The PL angiomatosis can usually unilateral in 80%, but can be bilateral in 20%. I see there is less than a minute for the meeting.
Recording.
Okay, like it. Yeah, so it's a case of an F2 with bilateral schwannomas, as you can see. So an F2, it's autosomal dominant, and then the mnemonics that that you can use and remember, which is multiple intracranial schwannomas, meningiomas, ependymomas. So these are the things that are associated with an F2, and then it's only astrocytoma excluded, which is associated with an F1. So miss me. That's the mnemonic that keep in your mind. So in this case, there's bilateral schwannomas, but maybe a little bit small meningioma here, but also there is enhancement of trigeminal nerves, which could be related to additional schwannomas within the trigeminal nerves. Okay. Yeah, good job. Next question. I mean, it's select all that apply, so you can select two. You don't need to change the answers. Okay, so it's a case of caudal regression syndrome. And most of the cases are sporadic, but it can, maternal diabetes is a risk factor. It can have some other manifestations, so it can associated with cardiac abnormality, GU, including hydronephrosis, renal agenesis or dysgenesis, GI, such as anorectal atresia or imperforated anus, esophageal atresia, duodenal atresia. Diagnosis can be done during prenatal ultrasound or MRI, and there are two types. So type 1 is the high abrupt termination of the conus, similar to the case that we saw, and they call it blunted or razor tip, like contour, and it will be associated with severe sacral dysgenesis. Or type 2, which is low-lying cord extending lower down, and then mild sacral dysgenesis. Okay, another case. Good job. Yes, so it's astrocytoma, and the way that you would tell it's astrocytoma, it's a solid and solid, enhancing solid and cystic lesion, and then no restricted diffusion. That's the diffusion, that's the ADC. So no restricted diffusion, and the enhancing nodule. So pilocytic estro, it's a grade 1. We said it's solid and cystic within midline or off midline. It can have calcification in 20%. The enhancement can be variable, but the most common one is non-enhancing cyst with enhancing mural nodule and doesn't have restricted diffusion. Okay, you can click on the finding. Okay, so that's the superior orbital fissure. And then we have here the carotid canal. The areas here, this is the inner ear structures. So cochlea, vestibule, semicircular canal. So it doesn't have anything to do with the orbit. That's where the superior orbital fissure. Okay, another case. Where is the right inferior orbital fissure? I like when we change answer. Okay, so that's the inferior orbital fissure. And then here we have the foramen rotundum. It could be this is part still of the inferior orbital fissure. However, I was asking about the right inferior orbital fissure. Okay, another case. Take a look. Wow, good job. Okay, so it's Alexander disease. It depends on the age of presentation. So the infantile form is more as a symmetric increased T2 weighted signal in bilateral frontal white matter. Juvenile form will have more as involvement within the cerebellum, within the brainstem, and cervical cord. With the Alexander disease, there is this, you get this nodular periventricular rim around the lateral ventricles, and then this rim can enhance. So it's one of the few diseases that can enhance, and these are related to accumulation of rosenthal fiber. It can be associated also with cavum septum pellucidum. That's another case in a 20-month-old patient. So we see the cavum septum pellucidum here. We see more as the signal, prominent white matter signal within the frontal horns of the frontal lobes, and then some signal abnormality within the cerebellum. With Alexander disease, if we are doing the MR spectroscopy, and I put this here just to compare it with Canavan disease. So in Alexander, you have low NAA, and that's the choline, creatine, NAA. Usually, normally, it should be the NAA is the highest, and then the slope of the curve, it should go high up toward the NAA. In Alexander, the NAA is low, and then there is lactate peak. Just to review these things, so metachromatic is more as lysosomal storage disease. It can present with confluent butterfly appearance of white matter signal abnormality. Early on will be sparing the subcortical U fiber, which is the fiber exactly next to the cortex, but later on, even this subcortical U fiber can be involved, and it spares the perivenular myelin. So there is venule running through the white matter, and spare these venules. That's where the myelin around these venules, that's what can give the tigroid or leopard appearance. There is no enhancement in this one. However, it can be associated with the cranial nerve and coda equina enhancement. Adrenoleukodystrophy is an X-linked disease, so it happens only in boys. There we can see 3 layers of involvement. The inner layer is the necrotic, and then the intermediate, it's more as the active demyelinating layer with inflammation. That's why it can have restricted diffusion and enhancement. And then the peripheral layer, it's more as advancing demyelination but without inflammation, so it doesn't give enhancement. It's a symmetric posterior distribution, rarely can have bilateral frontal distribution in around 10%. So just to review for these leukodystrophies, the main one that has some characteristic radiological finding that we can call on them. So Alexander and Canavan, both of them are associated with big head, and Alexander is more as a frontal white matter involvement. And if we are doing the more spectroscopy, then we would expect low NAA and enhancement in these periventricular nodules. Canavan is big head, however, the involvement of white matter is more as a diffuse subcortical white matter, and with MR spectroscopy, it will be elevated NAA, and there is no enhancement. Metachromatic is the most common, however, these have the 3 on the lower down has normal head, and the metachromatic, it's periventricular white matter involvement with the sparing of these perivenular myelin, resulting in tigroid appearance and no enhancement. Adrenoleukodystrophy, again, normal head, X-linked, so it's only boys, posterior usually with the involvement of the splenium of corpus callosum with enhancing intermediate layer. Lay disease, normal head, focal subcortical white matter, basal ganglia, subthalamic nuclei, and periaqueductal gray matter. Okay, another case. Okay, good. Yes, it's ependymoma. And you can see how it goes down through the foramen magnum, and it's also more heterogeneous. And there is some susceptibility signal related to either calcification or a blood product. And there is no restricted diffusion. So again, we said heterogeneous, arising from the floor of the 4th ventricle, has the plastic characteristic, more cyst and hemorrhage. 2/3 are infratentorial, calcification about 50%. Okay, another case. Yes, good job. Tuberous sclerosis. So a case of tuberous sclerosis with all the subcortical tubers, subependymal nodules, some of it can be calcified, and then this is all, and then we have the part of these subependymal nodules at the region of the foramen of Monro. So when you measure these things, the way that you would say it could be SEGA, the astrocytoma, is when you have size measurement of more than 12 millimeter, or on follow-up imaging, you see it as become bigger, then that's when you would say it's SEGA. Otherwise, even if it's within the foramen of Monro, it's the subependymal nodules. And if you see 2 next to each other, you should measure each one separate. So if there are 2 next to each other and each one is 6 millimeter, that doesn't put them as SEGA. However, each one is by itself, not the combined measurement. So tuberous sclerosis is a multi-systemic genetic disorder with epilepsy and multiple organ tumor and hamartomas. Classic clinical triad of adenoma, sebaceum, mental retardation, and seizure. Part of the CNS manifestation is, as we said, the subependymal nodules, which are hamartomas. and subependymal giant cell astrocytoma in 15%, which is WHO1, and the subcortical tubers, again, it's hamartomas, and there's about 4% of these that can enhance. Other systemic manifestation, renal, we have the angiomyolipomas and cysts, cardiac rhabdomyomas, lung cystic lymphangiomyomatosis or fibrosis. Solid organs, they can have adenomas or leiomyomas. Within the skin, we can have the different spots, ash leaf spots, or scalp involving scalp, hair, facial angiofibromas, Sjogren patches. And within the extremities, subingual fibromas, cystic bone lesions, or undulating periosteal reactions. Ocular, still we have the retinal hamartomas. Okay, another case. Take a look. Okay, that's good. I see a little bit of change in responses, but it's a case of infantile hemangioma. So what you see a solid lesion, and then there is some foci within the solid lesion, which is signal void, and there is no restricted diffusion. This is the ADC, and then this is the diffusion. So there is no restricted diffusion. So infantile hemangioma, most common vascular tumor of infancy, usually presents shortly after birth with a proptosis and the red mass within the skin, rapid growth during the first year, and then start to involuting later. And on CT or MRI, it's a solid mass with the signal voids that you can see, and there is no restricted diffusion. And that's the difference in any orbital mass lesion. If there is no restricted diffusion, then it's benign hemangioma. If there's restricted diffusion, then you would call either rhabdomyosarcoma in pediatric or lymphoma. Okay. I think this is the last case, fetal MRI. Okay, good. Okay. So variability in responses for this one. We'll talk about the large posterior fossa, because that's an important point to distinguish this one from other entities. It's the correct answer is the piriform aperture stenosis, but we will talk about this. So in the case of a lobar holoprosencephaly, with that one, so you see as there is the monoventricle and then a little bit of the cerebral mantle, but this is all connected together. There is a dorsal cyst posteriorly. However, the posterior fossa is formed, and if there is something, it will be smaller rather than being large posterior fossa. Just because of the dorsal cyst and the ventriculomegaly, rather than being a large posterior fossa. The entire entity just affecting the anterior portion of the brain. So that's what's going on. Initially, the brain has the primary vesicle. There is the prosencephalon forming the forebrain, mesencephalon forming the midbrain, and the rhombencephalon forming the hindbrain. With further development, we'll get the 5 secondary brain vesicles. With that, the prosencephalon will be separated to 2, the telencephalon forming the cerebral hemispheres, the 2 cerebral hemispheres, and then diencephalon forming the thalami and the hypothalamic region. So there is a disturbance in that separation. That's why these things look still connected together. And it's a spectrum of disease. There is no clear distinction. Sometimes it's very hard to say whether it's semi-lobar versus lobar holoprosencephaly. Overall, they will get single ventricle, absent or partial hemispheric and basal cleavage, incomplete interhemispheric fissure or Fox. There is azygous anterior cerebral artery, and then because it's a midline abnormality, so then there is facial defects, midline facial defects. With the A lobar, which is the most obvious one, we'll have what looks like a ball or cup forming the monoventricle, and then surrounding this is the cerebral mantle, which is just the dysplastic cerebral hemisphere, and then dorsal cyst with dysmorphic feature. We'll show you another case of A lobar. Again, the same monoventricle, the anterior mantle, the dorsal cyst, and the hypothyroidism. It's a very severe hypothyroidism, the two eye almost touching. That's on prenatal ultrasound. Again, the two eye are too close. The monoventricle on the coronal, the same here, and they can get an extra piece of bone superior to the orbit. They call it proboscis, and you see how even the frontal sloping for on the sagittal. Another case, 24-week fetus with a hypothyroidism, and they get central incisor instead of the two incisors. There's only one incisor. So again, it's midline abnormalities. So then you think even about the face, about any midline changes. Semi-lobar, so then with the semi-lobar, the frontal horns start to fuse. So it's still there is, it start to separate, but still there is more than 50% of it is fused, and then still the thalami and hypothalamus are fused. The difference to say this is semi-lobar is by having the posterior interhemispheric fissure. So posteriorly it starts to separate posteriorly, and that's when you would be able to say this is semi-lobar. And still you can have the dorsal cyst and the facial, midline facial abnormality, but it's going to be a little bit less than what you can see in A lobar. And that's an example of a case, little bit of hypothyroidism. And so there are certain measurements for the orbital diameter, but roughly speaking, if you should be able to place another orbit between the two orbits. If you are not able to place another orbit there, then it's hypothyroidism, which is the two eyes are close to each other. And then you can see here the monoventricle, the hypothalamic region, thalamus are fused, but posteriorly you start to have more separation, and that's the posterior fox here is separating the two hemispheres. With lobar, that's when we get more of the separation, and most likely it's only the most inferior frontal lobe that's still fused, but then you will have most of the ventricles are separated, so you can get a little bit of rudimentary frontal horns. Third ventricle will be formed. Corpus callosum, most of it will be formed, but for sure the septum pellucidum is always absent with all the holoprosencephaly spectrum. And this is all in comparison to hydranencephaly. In hydranencephaly, it's something, an injury happening in utero that affect the distribution of ICA, internal cerebral artery. So it's either vascular occlusion, infection, or trauma during the first trimester, which will result in absence of the cerebral hemisphere. However, the thalami, the brainstem structure, cerebellum, the fox is formed, and it's all separated. And then the just the front of the cerebrum, it can look as water bag, so there is no cerebral mantle. the temporal and occipital lobes are partially formed, so you can see some remnant of these. Just think about it as like an MCA stroke, and then all the MCA, but also the ACA distributions are, the ACA and the MCAs are gone, and macrocephaly. So that's how it looks in hydranencephaly. You see the thalami are separated, and then there is a little bit of the temporal lobes are there, but then the fox is there. So anteriorly things are separated. It's just and there's no anterior cerebral mantle. I think that's it for me. Any questions?